In 2018, a woman named Donna Penner walked into a hospital in Ohio for what should have been one of the happiest days of her life, a scheduled C-section. She was put under anesthesia. The surgery began. And then, somewhere between the first incision and the moment they pulled her uterus out of her body, Donna woke up. She was fully conscious, completely paralyzed. She felt the scalpel cut through her abdomen layer by layer. She felt the pressure as hands reached inside her. She felt them lifting organs. She tried to scream. Nothing came out. The paralytic drugs were still working. Her body was frozen. Her mind was wide awake and trapped inside. The anesthesia had failed. Donna is one of roughly 26,000 Americans every year who experience what's called anesthesia awareness, one in every 19,000 surgeries. The patient wakes up, the drugs meant to paralyze them keep working, and there is currently no reliable way for doctors to predict who it will happen to before they're already on the table. You're about to hear 8 things that can go wrong in an operating room that your surgeon will never mention when you sign that consent form. The operating room is supposed to be the safest place in the hospital, sterile, controlled, every instrument counted, every vitals monitor calibrated, staffed by people who spent a decade learning how not to kill you. And most of the time, it works. Most of the time, you go under. The surgery happens and you wake up exactly when you're supposed to with no memory of what occurred. But not always. Sometimes the machines fail. Sometimes the body does something no one predicted. And sometimes the system itself is the problem. These are 8 terrifying things that can happen during surgery. Number 8. Anesthesia awareness. Donna Penner's case wasn't unique. It wasn't even rare by the standards of surgical complications. Anesthesia awareness happens in approximately 1 out of every 19,000 general anesthesia cases in the United States. That's 26,000 people per year who wake up on the table, fully conscious, fully aware, completely unable to move or communicate. Anesthesia is not one drug, it's a combination. One set of drugs sedates you, shuts down consciousness, and erases memory formation. Another set paralyzes your muscles so you don't move during the procedure. Those drugs are delivered separately, and sometimes the sedation wears off while the paralytic keeps working. Your brain wakes up, your body stays frozen. Most patients report hearing conversations, the surgical team talking about their weekend, alarms beeping, instruments clattering on metal trays. Some report pressure, some report pain. All report terror, the kind that comes from being awake inside a body that will not respond. There are brain monitoring devices designed to detect awareness, EEG-based systems that measure electrical activity and alert anesthesiologists if consciousness returns. But they're not foolproof. They're not used in every surgery. And even when they are, some patients metabolize anesthetic drugs faster than the machines can detect. Every time you go under general anesthesia, there is a small, calculable chance you will wake up before the surgery is over, and you will not be able to tell anyone until it's already too late. Number 7. Surgical fires. In 2016, a woman undergoing a routine tracheotomy at a hospital in Florida caught fire. The surgical drape ignited. Flames spread across her neck and chest. She suffered 2nd and 3rd degree burns over 20% of her body. The fire was caused by a combination of 3 things that are present in almost every operating room: an ignition source, a fuel source, and oxygen. Here's the mechanism. Electrocautery devices, the tools surgeons use to burn tissue and seal blood vessels, reach temperatures over 1,000 degrees Fahrenheit at the tip. Surgical drapes, gowns, and alcohol-based prep solutions are flammable. And many surgeries, especially those involving the airway, use supplemental oxygen or deliver it directly to the surgical site at concentrations of 100%. Oxygen doesn't burn, but it makes everything else burn faster and hotter. All three elements come together in what's called the fire triangle: ignition, fuel, oxygen. Remove one, no fire. But in an operating room, all three are necessary for the procedure to happen safely, so the risk is always there. The most common sites are the head, neck, and upper chest, surgeries involving the airway, oxygen flowing near an ignition source with flammable materials in between. When it ignites fast. Flames can spread in seconds, and the patient, unconscious and draped, has no ability to react. Surgical fires are considered a never event by the Joint Commission, meaning they should never happen if protocol is followed. But they happen 200 to 300 times a year anyway, because protocol depends on human attention, and human attention in a 6-hour surgery is not perfect. Number 7. Wrong site surgery. In 1995, a man named Willie King walked into a hospital in Tampa, Florida to have his diseased right leg amputated. The surgical team prepped him, put him under, and amputated his left leg, the healthy one. Wrong site surgery is exactly what it sounds like: operating on the wrong body part, the wrong side, or in extreme cases, the wrong patient entirely. It happens roughly 40 times per week in the United States, about 2,000 times per year, despite decades of protocol designed specifically to prevent it. The most common errors involve left-right confusion, operating on the wrong kidney, the wrong lung, the wrong knee. Surgeons are required to mark the surgical site with a permanent marker before the patient goes under. The entire team is supposed to perform a timeout immediately before the first incision, verbally confirming the patient's identity, the procedure, and the correct site. It still happens. A 2006 study published in the Archives of Surgery analyzed 2,826 malpractice claims and found wrong site surgery occurring across every specialty: orthopedics, neurosurgery, general surgery, urology. In some cases, the site was marked incorrectly. In others, the mark was ignored. In others, the timeout didn't happen or happened while people were distracted. Human systems fail. Checklists get skipped. And sometimes a patient wakes up missing a part of their body they were supposed to keep. Willie King's surgeon had his medical license revoked. The hospital paid a settlement. Willie King spent the rest of his life as a bilateral amputee because someone in that operating room didn't stop long enough to confirm which leg was supposed to come off. If you're still watching, you're probably starting to question every surgical procedure you've ever trusted. Every time you signed a consent form without reading it. Every time you assumed the people in that room knew what they were doing. Good. Because what you just heard, anesthesia awareness, surgical fires, those are complications, things that can go wrong.
What I'm about to tell you next are things that happen on purpose. Things your body does in response to surgery that doctors can see coming and have no way to stop. And the scariest part? Most of them don't show symptoms until you're already on the table. Number 5. Malignant hyperthermia. Malignant hyperthermia is a genetic condition that approximately 1 in 100,000 people carry without knowing it. They live normal lives, no symptoms, no warning signs, until the day they're exposed to certain anesthetic gases or muscle relaxants commonly used in surgery. And then their body temperature spikes to 106 degrees Fahrenheit or higher. Their muscles begin to break down, and if it's not caught and treated within minutes, they die on the table. Here's what happens. The drugs trigger a massive release of calcium inside muscle cells. The muscles contract uncontrollably. This generates enormous amounts of heat. Core body temperature rises by 1 to 2 degrees every 5 minutes. The muscle tissue starts to cook from the inside. Proteins denature, cells rupture. The breakdown products flood into the bloodstream. Rhabdomyolysis, the medical term for when muscle tissue dissolves and releases myoglobin into the blood. Myoglobin clogs the kidneys. Kidney failure follows. Potassium floods out of dying cells and causes cardiac arrest. All of this happens in under 30 minutes if untreated. There is a treatment, a drug called dantrolene. It stops the calcium release and halts the reaction, but it has to be given immediately, and it has to be recognized immediately. Early signs include unexplained rises in carbon dioxide, muscle rigidity, and a rapidly climbing heart rate, all things that can happen in surgery for other reasons. The mortality rate for malignant hyperthermia before dantrolene was introduced in 1979 was over 70%. Today, with treatment, it's less than 5%, but that still means dozens of people per year die from a condition they didn't know they had until the anesthesia triggered it. There is no reliable pre-surgical screening test. The only way to know for certain if you carry the mutation is through muscle biopsy, an invasive procedure most people will never undergo unless they have a family history. You could be a carrier right now, and you won't know until the day you're put under for an appendectomy and your body starts burning itself alive. Number 4. Retained surgical instruments. In 2000, a man named Donald Church underwent abdominal surgery at a hospital in Washington state. The procedure went fine. He recovered, he went home. 13 years later, he began experiencing severe abdominal pain. Imaging revealed a 13-inch retractor, a metal surgical tool that had been left inside him during the original operation. It had been sitting in his abdomen for over a decade. Retained surgical instruments occur in approximately 1 out of every 5,500 surgeries. That's roughly 1,500 cases per year in the United States alone. Sponges are the most common, small gauze pads used to absorb blood, but cases have involved scalpels, clamps, retractors, and in one documented case, an entire 18-inch metal ruler. Operating rooms use strict counting protocols. Every instrument and every sponge is counted before the surgery begins and counted again before the patient is closed. If the counts don't match, the surgical team is supposed to stop, find the missing item, and if necessary, take an X-ray before closing the incision. It still happens. A 2003 study in the New England Journal of Medicine identified risk factors: long surgeries, emergency procedures, unplanned changes in the operation, higher BMI, any situation where the surgical field is more complex or the team is under time pressure. Most retained objects are discovered within weeks or months. Pain, infection, imaging ordered for unrelated reasons that reveal something that should not be there. But some, like Donald Church's retractor, go undetected for years. The body walls them off with scar tissue. They become encapsulated. And they sit there, silent, until they shift or erode into something vital. Removing a retained object often requires another surgery, which means another round of anesthesia, another incision, another recovery, and another opportunity for something on this list to go wrong. Every surgical instrument has a number. Every sponge has a radiopaque strip so it shows up on X-rays. And still, 1,500 times a year, something gets left behind. Remember Donna Penner, the woman who woke up during her C-section? She wasn't unlucky, she was statistically inevitable. Every single item on this list, the fires, the retained instruments, the malignant hyperthermia, the wrong site amputations, has a documented failure rate, which means every year a specific calculable number of people will experience these complications. The system knows it's going to happen, it just doesn't know to whom. And if you've ever had surgery or ever will, you're in that pool. Your body, your genetic mutations you don't know you carry, your surgical team's adherence to protocol on the specific day you're on the table. You signed the consent form, you trusted the system, And statistically, you'll be fine. But someone won't be. And the numbers say that someone is in an operating room right now. Number 3. Air embolism. An air embolism is what happens when air enters the bloodstream and travels to the heart or brain. In small amounts, the body can handle it. In larger amounts, it causes stroke, cardiac arrest, or death. It can happen in surgery in several ways. A central line insertion, a catheter placed into a large vein near the heart. If air enters the line, it travels directly into the right side of the heart. Neurosurgery performed with the patient sitting upright. The position causes negative pressure in the veins of the head and neck. If a vein is cut, air can be sucked in. Once the air is in the bloodstream, it forms bubbles. Those bubbles travel to the heart. If enough air enters, it creates what's called an airlock. The heart tries to pump, but it's pumping foam. Blood flow stops. The brain is cut off from oxygen. Cardiac arrest follows in minutes. Small air embolisms, the kind that involve just a few milliliters, may show no symptoms at all. Moderate ones cause confusion, chest pain, and shortness of breath. Large ones, anything over 100 milliliters entering rapidly, are almost always fatal. It's estimated that clinically significant air embolisms occur in 1 out of every 1,000 neurosurgical procedures performed in the sitting position. The risk is high enough that many surgeons have abandoned the sitting position entirely in favor of other approaches. But it's not always avoidable. Some surgeries require specific positioning. Some require access to veins where negative pressure is unavoidable. Anesthesiologists monitor for air embolism using Doppler ultrasound. The sound of air bubbles moving through the heart is distinct. If detected early, the surgery is stopped. The patient is positioned to trap the air in the right ventricle. A catheter is inserted to aspirate it out. But early detection requires the monitor to be in place, the volume to be turned up, and someone to be listening at the exact moment the air enters. And in a noisy operating room during a complex procedure, that doesn't always happen. You can die from something as simple as air entering a vein, something invisible, something that weighs nothing. And it happens often enough that monitoring for it is standard protocol in certain surgeries. Number 2. Nerve damage from positioning. Before surgery begins, you are unconscious, completely unable to move or feel pain, which means the surgical team positions your body in whatever way gives them the best access to the surgical site. Arms extended, legs spread, head turned, pressure on joints, and you have no ability to tell them if something is wrong. Nerve damage from surgical positioning occurs in approximately 1 out of every 1,000 surgeries. The most common is brachial plexus injury, the bundle of nerves running from the neck through the shoulder and into the arm. If the arm is extended too far or if pressure is applied to the shoulder for too long, those nerves can be stretched or compressed. When you wake up, your arm doesn't work. You can't lift it. You can't feel your fingers. The damage can be temporary, lasting weeks or months, or it can be permanent. The ulnar nerve, the one that runs along the inside of your elbow, is especially vulnerable. Resting your elbow on a hard surface for too long causes that tingly, funny bone sensation. Now imagine that same nerve compressed for 6 hours during a lengthy surgery while you're unconscious and unable to shift position. Ulnar neuropathy. Loss of sensation in the ring and little fingers, weakness in the hand, difficulty gripping objects. Perineal nerve damage occurs when pressure is applied to the outer side of the knee. The nerve runs close to the surface there. If a patient is positioned on their side and a support is placed against the knee, the nerve can be compressed. The result is foot drop, inability to lift the front of the foot. Walking becomes difficult. Recovery can take months, and some cases never fully resolve. These injuries are considered preventable. There are guidelines for how to position patients safely, padding for pressure points, limits on how far joints can be extended, frequent repositioning during long surgeries. But guidelines depend on attention because what you just heard, anesthesia awareness, surgical fires, instruments left behind, the wrong site amputations, those are complications.
things that can go wrong, risks listed in the fine print of the consent form you signed without reading. What I'm about to tell you is different. This isn't a complication. This isn't human error. This isn't a machine that failed. What I'm about to tell you is something the medical system does on purpose to hundreds of thousands of patients every single year, and it does it knowing, with published peer-reviewed evidence, that the procedure doesn't work. In 2002, an orthopedic surgeon named Bruce Moseley published a study that ended careers and sparked an ethical crisis in the medical community. He proved that one of the most common surgeries in America was indistinguishable from doing nothing at all. Number 1. Procedures that don't work. Bruce Moseley was a highly respected orthopedic surgeon in Houston, Texas. For years, he had been performing arthroscopic surgery on patients with osteoarthritis of the knee. It was a standard procedure. Go in with a tiny camera and instruments, scrape away damaged cartilage, flush debris out of the joint. Patients reported improvement. Insurance covered it. It was considered good medicine. But Moseley started to suspect something. He had noticed that some of his patients seemed to improve before they even left the recovery room. Too soon for healing, too soon for inflammation to subside. He designed a trial to test whether the surgery itself was doing anything. He divided patients into 3 groups. One group got the full arthroscopic procedure. Another group got a partial procedure, just the flushing, no scraping.